All right, everybody, welcome back to Dr. Melanie Gillingham, who is a research rock star in the FED community and one of our leading KOLs. And joining her is Dr. Jeffrey Vinocur. So let's get to know Dr. Vinocur a little bit before we get started. Dr. Vinocur is a pediatric congenital cardiologist and electrophysiologist. He attended medical school at the University of Pennsylvania, followed by training in Hartford, Minneapolis, and Toronto. Dr. Vinocur is just wrapping up at the University of Rochester in upstate New York, where he has had the privilege of taking care of some very special patients with mitochondrial and metabolic disorders. He will be starting a new adventure next month at Yale University and the Yale New Haven Children's Hospital. He has particular interest in genetic heart rhythm disorders and is taking an integrated, multidisciplinary approach to the cardiac manifestations of complex medical conditions. So before we get started, just a reminder, drop your questions in the Q&A, and Dr. Gillingham will be on to join us for the Q&A session of the presentation. So please join me in welcoming Dr. Vinocur.
Hi, everybody. Thanks for inviting me. I was asked to give sort of an introduction and foundation into heart rhythm problems as they're becoming perhaps more a topic of conversation with metabolic disease these days. So to start with the non-electrical side, right, the job of the heart is to pump the blood around. There's a right side that pumps the blood to the lungs and a left side that pumps the blood to the body. And the lower chambers, the ventricles, are what do the bulk of the pumping work. And for our purposes here, we're going to focus on the left ventricle, which is the chamber that pumps the blood to the body and is the chamber of importance for most of the metabolic and mitochondrial disorders. One of the questions I know that had come up is about these different measurements that we do, talking about the heart and what's electrical and what's squeezing function or pumping function. So the squeezing strength of the muscle of the heart is described using different terms. So we sometimes call it left ventricular function or left ventricular contractility. So that's how much the muscle can squeeze. And in pediatrics, we most often just use descriptive words. We say it's normal, or it's mildly low, or it's moderately low. But some doctors in some hospitals prefer to report out numbers, and so you will sometimes see these numbers and talk about these numbers. There's two main numbers that we use. There's the shortening fraction, which is a measurement of the diameter of the chamber, right? So while the chamber's expanding and contracting, we can measure the diameter when it's at its biggest and the diameter when it's at its smallest and do the percentage. Or the ejection fraction is a measure of volume. So we imagine like it's a beaker full of water, and you figure out how many teaspoons of water are in it when it's full and how many teaspoons of water are in it after it pumps. And so they're two very different numbers. You can see the normal value for one is in the 30s and the normal value for the other is in the 60s. It's important to remember that nobody is supposed to be 100%. To be 100%, the heart would have to pump every little drop of blood out, and that's just not how it works. If I can make that animation go again, let's see here. The heart pumps, from bigger to smaller, but it doesn't pump all the way to empty. So I think sometimes people will hear a number, like an ejection fraction of 50%, and think it means that the heart is, half as strong as it should have been, when in fact 50% is only a little bit low, because normal would have been 60 or 65%. All right. When we have abnormal left ventricular function or abnormal squeezing strength, the way I would think about it here is that this could be a short-term issue or a long-term issue. So anytime the body is under tremendous stress, whether that's an infection or a metabolic crisis, the heart can have trouble working the same way all the other organs might have trouble working. right? When you're very ill, your kidneys may have trouble, your liver may have trouble, all sorts of things happen. It's not surprising in any sort of bad illness to have short-term changes in left ventricular function. And sometimes those are kind of found by accident. You know, we decided to look on ultrasound and we see it, but it's not the thing that's bothering you today. And sometimes they can be extremely severe. But often that will rebound. You know, once the issue settles, and this happens even more maybe than most with metabolic disease, because the amount of change that can happen so quickly is very impressive. And perhaps there is some lasting effect or not. I'm not sure we know for sure. But that's a sort of a temporary thing that happens in the setting of usually an acute hospital stay. Or there can be long-term changes in left ventricular function, and this is what we call cardiomyopathy. In most people, mild and even moderate changes on the echo, on the ultrasound, can be not enough to manifest any symptoms at all. You know, if someone is a vigorous athlete, they may be able to tell, you know, that something has changed in their endurance. But we have many children who are walking around with mild and moderate and even sometimes severe left ventricular dysfunction that has come on gradually and not really recognized. But if symptoms are going to be visible, the main symptoms are exercise intolerance, shortness of breath with exercise, sometimes fatigue, although by comparison to all the other causes of fatigue in children and teenagers, I don't get as suspicious unless it's impairing ability to be active. Originally, when I was making this slide, I was thinking about writing temporary and permanent, but I don't think that's a fair description of these two things, because even the sort of long-term changes in left ventricular function can improve with treatment. They can improve with control of the underlying illness, and they can improve with particular treatment strategies that are good for left ventricular function. There are certain medications that we use when there's poor left ventricular function of any reason that can result in partial or even complete normalization of how the heart is squeezing. Okay, so I wanted then to move on to the electrical part, which is the main purpose of our talk today. So the heart has the 4 chambers, like we talked about at the beginning, and then in the yellow here is the electrical system. So there's a part up here that decides how fast the heart should go, depending on whether you're resting or exercising or feeling ill. And there's this connection from the upper chambers to the lower chambers, and then a whole mesh of electrical wiring to help the heart muscle get the signals, because it doesn't matter whether the heart muscle can squeeze strongly or not if it's not squeezing at the right time. So the normal heart rhythm, which we call sinus rhythm, I think of as sort of having 2 features. It comes at a normal heart rate, and the normal heart rate depends on how old you are and also what the situation is. Mostly we talk about heart rate awake, sitting in the doctor's office, or awake laying down, getting an EKG done. But for example, if you have an illness and some nausea and vomiting and you're in the ER, I would expect you to be higher, right? If you weren't 120, that would probably be odd. And so we judge the heart rate in the context. Similarly, at nighttime, many people will go less than 60, and that also is often normal. The other characteristic of the normal heart rhythm is that it comes in the normal pattern. So the normal pattern of the heart rhythm is for the upper chambers to squeeze, then for there to be a small delay, and then for the lower chambers to squeeze. And so to be truly normal, you need both parts. You need the rate to be normal, and you need the pattern to be normal. That being said, not all abnormal rhythms are the same. There are some rhythms that are abnormally slow. They're not as big of an issue in the metabolic disorders, and I wasn't going to spend much time on them, but we do see them in other mitochondrial conditions. Kern-Sayer is the one that's maybe the classic. Here today, I think we're mostly talking about abnormally fast rhythms, and we can describe those or classify those in a lot of different ways. We can talk about how long they last. Do they come for just a single heartbeat? Do they come for a short burst? Or do they come for a longer period? And then over on the right side, I put the sort of medical terminology that goes. So 1 beat at a time, we would say, is a premature beat or a premature contraction. A short burst, say 3 fast beats in a row or 5 fast beats in a row, we would say is non-sustained. And longer, people talk about different cutoffs, but maybe 30 seconds, we would say is sustained. We also describe them by their locations. So they could come from the upper chambers, they could come from the lower chambers, and there's actually some that sort of involve the interaction of the two. So for example, you might hear someone say they had a premature atrial contraction. So that's 1 extra beat from the upper chambers. Or a premature ventricular contraction, that's 1 extra beat from the lower chambers. Keep in mind, the heart beats about 100,000 times a day, about 1 million times a week. So 1 beat here and there is not a surprise. In fact, even people with no underlying condition at all will have an occasional abnormal beat. So in terms of less serious rhythms, so abnormal but less serious, we have the rhythms that are in the upper parts of the heart. So atrial tachycardia, supraventricular tachycardia, and those can be annoying, they can be medically important, but they're usually not life-threatening. And the main symptom with these is heart racing. Some people will say, heart racing plus chest pain, heart racing plus difficulty breathing, heart racing plus dizziness. But almost always they can say that the heart racing is the big problem. On the other hand, some of the abnormal rhythms are more serious. And mainly here, what we're talking about is 1 rhythm called ventricular fibrillation. That's when the heart goes very fast and kind of like chaos. So no pattern at all. And as a result, no blood gets pumped. And depending on how long that lasts for and what kind of medical attention is available, that can cause fainting followed by waking up. That can cause fainting with ongoing loss of consciousness and no meaningful breathing that we call cardiac arrest. And if cardiac arrest happens and there's not adequate medical care available, or occasionally even if there is medical care, particularly if the body is really out of whack before it happens, that can be impossible to reverse and ultimately fatal. The other kind of serious rhythm is called ventricular tachycardia. That's where the heart goes very fast. Sometimes it's more chaotic, sometimes it's less chaotic, but it's not as crazy as the VF. Some blood usually still gets pumped around. And so depending on the situation, some people will feel a fairly severe rapid heart rate sensation, and others will progress sort of all the way to these symptoms like you see with ventricular fibrillation. Okay. Another thing I was asked to talk about is the different tests that we do to evaluate how the heart is doing. So in terms of the heart pumping function, the squeezing strength of the muscle, The main test that we use is ultrasound, which for some reason we call echocardiogram, or people will say echo. I don't know why we call a kidney ultrasound and a heart ultrasound and echo, but that's the way that it is. It's the same technology you would get for any other body part. That we put the gel on and we hold the sensor up to the wall of the chest and look at what the sound waves find inside. The other test that we occasionally do if the echocardiogram is abnormal is cardiac MRI. And it has a few advantages, but the main important one is that it can actually tell if there's scarring in the heart muscle. So for example, if somebody had a bad crisis and their echo was abnormal at the time, and afterwards it seems like the echo has improved, we can try to look if there is any residual damage building up in there as a result. Moving on to how we evaluate the heart rhythm. So I think the first test that almost everybody has heard of is ECG or EKG. Those are the same things. This is a German abbreviation with K for cardiac. And so in theory, in English, we should say ECG, although you will see a lot of people do either one. So ECG is a 10-second heart recording. So we get the stickers on, we hook it up to the computer system, and here's your little snapshot of a 10-second period. Another very common test is the Holter recording. This is an odd name. I think it's the name of a scientist who figured out the technology. It doesn't mean anything. Where we do 24 hours or 48 hours or 72 hours of heart rhythm recording. It's a few less stickers than ECG normally. Often there will be 3 stickers or 4 stickers or 5 stickers. And it comes with a little apparatus that goes on a belt or in a pocket or in a little carrying case. And you go about your business. And so that gets us a recording of every single heartbeat that happens over that period of time. You will sometimes hear people talk about longer term monitors like 7-day or 14-day monitors that are done in a similar way to Holter. So we get every single beat recorded. That's still kind of newfangled and not always used, but some places have access to those equipment. The third one in this family is the stress test, where you get your ECG stickers put on, and then you go on the treadmill or sometimes on a stationary bike for usually about 10 minutes. And we record all the heartbeats that happen during that time. Then there are a few sort of longer term monitors that we use in different situations. So one family of equipment is called event monitors. These come in 2 varieties. So there's external monitors that are not attached to the skin. So this is something that you carry around, and when you feel your symptom, for example, palpitations, you take it out and you make a recording maybe that lasts for 30 seconds or 60 seconds. In the upper picture, you see one of the kind of medical prescribed event monitors, where it has these little electrodes on the back, and you just touch it against your chest or you touch it against your fingers of your 2 hands, and it can make a recording and save it and transmit it. This is very similar to technology that's now available to anyone, who wants to buy it in either the newer generation Apple Watches, or there's a standalone piece that's made by a company called KardiaMobile, which connects by Bluetooth to your smartphone, and you just carry this little piece around, and whenever you would like to make a recording, you can. And so, in all honesty, they're about the same in terms of recording capability. These get covered by insurance. This you buy out of pocket. But the general idea of it is about the same. it only makes a recording when you ask it to. And so you just get 30 seconds or 60 seconds of a snapshot. There are also external monitors that you wear attached to your skin. And most of them have stickers like a Holter, although there are some now that are sort of one big sticker that they call a patch. It's kind of like an enormous Band-Aid with the technology built into the adhesive of the Band-Aid. And those are typically done for 30 days, although sometimes people will say, oh, we're only going to do 2 weeks or 3 weeks or something. The advantage of those is that they can record on their own. So if an abnormal rhythm happens while you're asleep, the computer is able to notice it and make a recording. Or if you have a very short episode, like suppose you have racing heartbeat sensation that only lasts for 2 seconds, you wouldn't be able to get one of these monitors out and activated, but the wearable event monitors have a little memory. And so when you hit the button, it can go backwards, perhaps 30 seconds, it depends on the model, and get us a snapshot of an episode that has already stopped. There's also an internal monitor that works about the same way, except that it's implanted. So there's several of these from the different companies, but they're all pretty similar in size. You can see people like to compare them to paper clips. These are the big paper clips, not the little paper clips. And they go in under the skin, usually towards the middle of the chest, although we do a variety of things depending on the situation. And they live under the skin for 2 to 4 years, and they watch the rhythm. They can record whenever they see something abnormal, or also anytime you log in that that you felt a symptom. So if you have a palpitation or you have a fainting episode, you can signal to the computer that you'd like to make a recording, and it will go ahead and do that. Another question is, how do you pick between all of these monitors? So if there are symptoms that we're trying to sort out, somebody has fast heartbeat sensation or fainting episodes, then we pick a monitor that will let us answer that question. So if the episodes happen several times a day, we could put a 24-hour Holter and expect that we would record one. If the episodes only happen every few weeks, then we might need a 30-day monitor, or perhaps they are even less than that, and we need an implantable monitor. The other question is, what value do these monitors bring for people who don't have any symptoms? And it depends on the situation. If we're just kind of checking on the rhythm because we're generally curious, we probably would do a 24-hour or 48-hour Holter. But it depends. If we're curious about a condition that can be worse with exercise, we might do a stress test. If we're curious about a condition that only happens at nighttime, maybe a 24-hour monitor that you don't even wear for all 24 hours would be enough. Sometimes we'll tell kids that you can take it off before school in the morning because all we really wanted to know was what happened in the middle of the night. Depends on the situation. So, with all that as background, what do we have to recommend? I have to be honest, I have advice for people with symptoms. It's very hard to know yet what to do without symptoms. So the symptoms that we're worried about in terms of the heart rhythm are rapid heart rate, especially sudden and or severe rapid heart rate. So somebody who doesn't get a lot of exercise and it starts to be summer and they're going to try to do some exercise, very often will say, oh, I feel a little short of breath, or I feel a little racing heart when I try to exercise. And that's not likely to be anything bad. But sudden episodes where it's like you flip a light switch, they feel normal and then bang, they feel fast, are often suspicious for being a rhythm problem. Fainting that occurs with exercise is always very concerning. Fainting at other times, it's harder to know. Many people, especially teenagers and young adults, are predisposed to fainting. When you stand up too quickly, if you haven't had breakfast, if it's hot weather and you didn't have enough to drink. And most of those are benign and don't mean anything abnormal about the rhythm. Sometimes it's really clear to a family and they don't even bring it up to the doctor. Sometimes it will come up to the primary care doctor and they'll know that it's benign and not recommend anything further. And sometimes if people aren't sure, it will come to see a cardiologist and we may hear the story and say, we know for sure what that is. We don't need any other testing. Don't worry about it. Have more to drink. But it varies. People who have sudden fainting without a trigger, especially if you faint kind of hard enough to injure yourself, it may be worth some evaluation. For people who don't have symptoms, we're still learning. I think given what we're starting to understand about some of the metabolic conditions, there's probably a group of patients who having a regular checkup with a cardiologist might make sense. But I have to admit, I don't think we know which tests to do, how often to do them, or how to interpret the results. This is all still being worked out. Finally, the last thing I wanted to sort of put in for background, because I think it will be a topic of discussion, is about implanted defibrillators. So probably most people are familiar with external defibrillators that you see on the wall if you go to the gym or certainly at the airport or a shopping mall, that says in case of emergency, here's a defibrillator. Those you put on the outside of the person who's having the heart problem, and they can reboot the heart back to normal. We also have internal defibrillators. There's two big types. The more traditional type goes up by the shoulder and has a wire that goes through the bloodstream to the inside of the heart. And there's a newer type where the box goes on the side of the chest and the wire stays on the outside of the chest over near the breastbone. There's certainly differences between them, but I think not to get into today. When do we use these? So we typically recommend defibrillator for somebody who has previously had sustained, dangerous, abnormal rhythms, right? So rhythms more than 30 seconds in duration that look dangerous. And we usually recommend them for people who've already had a cardiac arrest with a fast rhythm like VT or VF that they were able to be rescued from. There's a few exceptions, right? So if you have a cardiac arrest in the setting of everything else being crazy, your kidneys are out of whack and your potassium levels are out of whack, we don't necessarily make anything out of it. But most people who've had a cardiac arrest would end up getting a defibrillator. The harder question is when would we do a defibrillator prophylactically? So in somebody who has not yet had a serious rhythm issue. And honestly, we don't really know the answer to this question in any condition, including common conditions, let alone in the setting of rare medical diagnoses. Traditionally, people who have severe abnormality of their left ventricular muscle strength, we have recommended prophylactic defibrillators, although I think in the recent years that the debate about this is sort of reopening. And we sometimes talk about defibrillators when there are other worrying findings. So somebody who has a medical condition that puts them at risk for sustained VT or VF, but on Holter has short episodes of VT. Maybe. we would love to have research to tell us, and unfortunately, in many conditions, we don't. And so often this ends up being a very long personal discussion. The issues are, it's very hard to predict the future, and these are devices with downsides. They're great if you really need them, but they come with their issues, both at the time of the implant and down the road. And so we really don't want to be putting defibrillators in tons of people who don't need them. And the trick, unfortunately, would be deciding who's going to need them and who isn't, and only offering defibrillators to the right group of people. And that's a great trick. If anybody knows the answer, I'd love to hear it. All right. I was asked to leave a lot of time for discussion, so see how we're doing.
All right. Welcome, Dr. Gillingham. Dr. Gillingham, do you want to kick us off with Q&A? Share any comments or any information, because I've got some questions that have come in through the Q&A. I'll let you guide us.
Okay, I would say that was great. Thank you so much, Jeff, for that presentation. It really broke it down for us. And I think we'll just go on to questions parents might have.
Okay, great. So there have been lots of questions asked about whether or not, which tests or which monitoring devices are appropriate for which ages. Like, is a stress test appropriate for a young child?
Yeah, that's a great question. So depending on development, coordination, different things, I would say most children can do a stress test sort of by early elementary school, 6, 7. They may not be perfect. It depends a little bit, right? If they have a treadmill that, grandma uses and they play on it on Sunday afternoon, they may do better than somebody who's never used a treadmill before. There are certainly, 4 and 5-year-olds who have done stress tests, but I think it really depends on the kid at that age. In the younger kids, if we want to get that kind of information, most often what we do is we put a 24-hour monitor and tell them to go home and run around in the backyard and see what happens when their heart rate goes up. And it's not quite as high resolution data, but it gets close to the question.
Can I ask, for you, the few FAO patients that you followed, have you used stress testing to? I'm not aware that it's been highly productive in this population.
I have not. Well, actually, so in certainly the LCHAD that you and I have spoken about the most, I don't think I've seen anything of value. I do believe we tried it.
Okay.
So when somebody is having abnormal rhythms, frequent premature ventricular beats, it's something we often do in anybody who has those for any reason to try to understand, what does adrenaline do to them? Does it flare them up, or do they quiet down? I do have one patient with propionic acidemia who actually does have a pretty abnormal response on stress test.
Stress test.
Yeah.
Okay.
Interesting. Do you find that there are any particular FAOD diagnoses that tend to be more susceptible to cardiac issues?
I would say that in the literature, the bulk of the patients that have had sudden ventricular, either VTAC or fibrillation, have been in the VLCAD and LCHAD populations. Not so much with adult onset CPT2. It can happen in the early infant CPT2, more severe form. And I haven't seen it reported much at all in MCAD.
Do you recommend, even for patients with no cardiac symptoms, that they regularly have an EKG?
I'm kind of coming down that they need to see a cardiologist every year. Yes, I just think it's good to check in regularly. I'll defer to Dr. Vinocur, but it makes me a little nervous to not see a cardiologist on a regular basis.
For the diagnoses you think are at higher risk, I mean, I think it's reasonable. I have to admit, we don't necessarily know then what to do. We can certainly watch the echoes, right? So we have cardiomyopathy, you know, I think as a not tremendously common, but not unheard of issue. And that's something that's easy to monitor and to have some idea what to do when you find. The question about who's at risk for a sudden life-threatening arrhythmia is really hard.
Agreed.
And so, how often should we test with which tests, and what do we do with the results? Is tough. On the other hand, the evolving experience, as I am learning, you know, from my few patients, is worrying. And I think, you know, it's a mix, right? So many metabolic diseases, in the setting of crisis, the heart gets all out of whack. And I think for the most part, what we learn from that is we need to have really good treatment plans, and hopefully everybody does, right? You start to have things not perfect, and you come into the ER and you get your IV fluid just the way they should be, and whatever other supplements, if that's appropriate for your condition, and try to stabilize things as fast as we can. And hopefully the heart will sort of weather the storm and not exacerbate the situation. The bit that's, I think, more worrying is the relatively small but real number of children and young adults who've had events when they are well. And we're going to try to dig into this and see if we can find patterns, but it's tough. These are very rare diseases, and it may be some time yet before we really know what the right thing is.
Yeah. So along that same line, would you recommend for the patients that have the diagnoses that are more susceptible to cardiac issues, that if they have a medical crisis and they end up going to the hospital, that they request to have an EKG done as a preventative measure and precaution?
I think it's reasonable to do. I don't know in this group of conditions that we necessarily have any warning sign in the 10-second recording that we would say is a big red flag. And that's not necessarily true with some of our related conditions. On the other hand, it doesn't hurt, it takes 2 minutes, and it's cheap. So honestly, why not, right? Like, if you have an at-risk condition, it's the easiest thing.
Yeah.
The part
I would say with
more,
go ahead.
I was going to say the part that's probably more valuable, which would probably happen automatically in most hospitals, would be to be on a heart monitor till the test, right? That either you're in the ICU, or if you're not in the ICU, that you're in a part of the hospital where the nurses have the capability of having you on a monitor, so that at 3 a.m., if something starts to happen, they find out about it 5 seconds later, and not next time somebody checks on you.
Okay.
I agree.
Good.
And I think the other test that you might think about if you're in rhabdomyolysis crisis would be an echocardiogram, because the more likely scenario is a cardiomyopathy developing as you're in metabolic crisis, is probably the more common description in the literature than the rhythm abnormalities. So doing an echo at that time is a good idea.
Okay, great. Next
and
question.
Hopefully, if you have a diagnosis, that should be pretty clear, right? Like if you're ill enough to be in the ICU, I would hope that everybody's already thinking that direction. The place we sometimes have trouble is when people come in with their not previously diagnosed condition, and everything is going wrong, and it's sort of still a puzzle. it may take a little bit, but of course we can't give advice to those people because they're not the ones here to talk to today.
Right. So next question is it normal for is it normal for ejection fractions to change? This mom is saying that her daughter's changes from normal to borderline, normal to low, and is that something they should look into?
Yeah, so it's a great question. So if you do an ejection fraction 3 days in a row, you never get the same number, right? It's like if you go for blood work, you look at any number on your blood work, it's never identical to last time, right? There's a little bit of natural variability. In addition, if you've ever tried to look at an ultrasound, they're pretty fuzzy. And so even if you have the identical picture and you show it to 3 different doctors, you may get slightly different numbers just because you're trying to decide where in the fuzzy picture is the actual border of the heart. In addition, the actual well-being of the heart muscle can change from day to day. And I think people who have, have a condition where there's a dietary modification or a supplement or whatever, and they're better or worse with complying with that, may see some changes over time. People who have higher blood pressure and then we get them on medicine and their blood pressure comes lower, the heart will feel better and the ejection fraction will improve. So we try not to overreact to little changes, but if over time there's a consistent pattern that it's like, either normal or borderline, the truth is probably in the middle, right? That we're just kind of at the low end of normal. And that's not bad, but, it's a reason to be watching, which it sounds like they are.
So we have a mom that is asking about the correlation between pulmonary function tests. MEP and MIP have dropped extremely to severely low. Should they be concerned about cardiac issues as well?
Yeah, so the left ventricle is not typically affected by how the lungs are doing. People who have significant lung problems from any cause, there can be additional stress on the right ventricle. We haven't spoken much about that today because it's not usually the problem. But I think anybody who has sort of major ongoing pulmonary issues, it's worth asking the pulmonologist, do they think we need to be looking at how the right heart is doing? And the pulmonologists are all used to that because there's a number of other lung problems where we often get heart side effects. And so they should be able to give you personalized advice on whether this situation is one that they would be worried or not.
Yeah, that's good. So, and Dr. Gillingham, I'll throw this back to you. Someone is commenting, saying that their son's team, they do an annual echocardiogram, but they don't actually see a cardiologist. Do you think that's sufficient, or would your recommendation be that they actually see a cardiologist?
Well, I think Dr. Vinocur's point is well taken, that they could see the cardiologist, but the cardiologist could look at the echo and say it's normal, and we're really not clear on what other tests would be warranted or necessary. So I think that the echo is kind of the main thing to monitor for cardiomyopathy. We're just beginning to get into what might be associated with arrhythmias, and so I don't think we know yet how detailed monitoring we should do. Should we do Holters or longer term monitoring? I think that's going to be on a case by case basis.
Yeah, and I think you've already answered this question, Dr. Vinocur, but there's a question that says, are heart arrhythmias and long chain FODs being correlated with sudden or severe health issues or cardiac arrest?
And I think we have a handful of cases that we think are, correlated in terms of, do we know how to predict them? Boy, I don't know yet.
Yeah.
I do think the one thing we'd have the prize. I think the one thing that we are seeing is that it's not always correlated with rhabdomyolysis. And I think that's an important point for families and patients to be aware of. If they start feeling that racing or have the fainting that Dr. Vinocur talked about, I would get checked out quickly, even if they're not seeing dark urine or muscle pain. So we have seen several cases where it's not. I used to think years ago that it would always be associated with a rhabdo episode, and we're seeing cases where it's not. And I think that's important.
Yeah, I mean, it would be interesting to understand, like, you're looking at an athlete, right, who has sudden cardiac episodes. Could they be in an episode of rhabdo, and it's not something that, they don't have, they may not have an FEOD, so it may not even be something they're paying attention to. So, I mean, like, all that's so interesting to me to understand. Yeah. So I want to just talk for a second about the at-home EKG monitor.
Yeah.
Right? Because now with technology, we have the ability to check and, be our own doctor at home, if you will. And so can you talk a little bit about, I don't want patients all to run out, grab the EKG monitor, see something go awry, and just, it's a good and bad thing, right? Because you can put yourself into a constant state of panic. I know I had checked my blood pressure every day, and sometimes it just that makes my blood pressure go up and send me over the edge. So I want to be thoughtful and, just talk about making sure we're smart about how we're using those at-home devices.
Yeah. So for situations where we're trying to answer a question, right? So somebody has episodes of heart racing or episodes where they feel skips, and we're trying to get a clarification on what that correlates to. I mean, honestly, the sort of personal monitors are at least as good as the ones that we prescribe, with the sort of exception of you don't get anybody to review them in the moment. You have to wait till your appointment or send it in or what have you. To sort of just be using to see what's going on, I would be careful. I think, that technology, the kind of automatic detection part of it, is designed for elderly people with a rhythm called atrial fibrillation. And I think there will be both unnecessary kind of concern at times and the potential to miss things that are important when we use it for other purposes, right? So in an elderly person where they're looking for atrial fibrillation, the technology is intentionally trying not to flag PVCs, because there's tons of PVCs as people get older, and you don't want to get excited about them when that's not really what you're looking for. And so I think it's potentially a fairly inaccurate thing. Not the recording, like the actual printout of the strip. If you show a cardiologist, they would be happy to tell you what it means. But the automatic, the sort of artificial intelligence part of it is not optimized for this. And I would be hesitant to make much of it.
Yeah, absolutely. A couple more questions. We have an attendee who's asking about helping to understand children's symptoms and kind of helping them to understand how to describe these rapid heartbeats, or any thoughts or insight about helping parents to help decipher that in language that they can use with kids.
Yeah. Up until probably mid-elementary school, the kids describe it the way they describe it. We often will hear, jumping or bouncing, dancing sometimes, thumping. Sometimes people will be, you know, like a rabbit's foot, thump, 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 thump.
Mm-hmm.
And in the younger kids, sometimes they just say it hurts because they don't really have a word for it feels weird. And the only thing they know how to explain is that it hurts.
Yeah.
I mean, at some point, all you really need to know is that they have a question about rapid heart rate and sort of how often and how long it lasts.
Mm-hmm.
So as much as if you came in as an adult, we would say, you know, tell me more, use more adjectives. What did you feel? In the younger kids, we don't spend a lot of time trying to dig the description out and just answer the question by using an appropriate monitor, because once we know there's a question about palpitations, it's pretty easy to sort that out, right? You figure out how often does it happen, and you give them a monitor that correlates to, you know, the appropriate time period to be monitored.
Okay, that's great. So we've talked a lot about identifying the symptoms, monitoring the heart rates. So you're diagnosed with a cardiomyopathy. How is it typically treated?
Yeah, so cardiomyopathy in this situation is usually that the heart muscle is not as strong as it should be. There's actually other kinds of cardiomyopathy where the heart muscle is too thick or various other issues. But I think for this group of diagnoses, we're really talking about the heart muscle strength being less than ideal. And often that comes together with the heart being dilated. And so sometimes people will talk a little more about one or the other, but they're kind of cousins of each other. Often the most important thing is to optimize the underlying medical condition. But if we've done that and there's still abnormal left ventricular strength, then typically what we do is we extrapolate from studies in adults with cardiomyopathy for other reasons, and we do things like use blood pressure lowering medicine, even for people with normal blood pressure, because it makes it easier for the heart to pump. And use some other medicines potentially that slow down the development of scarring within the heart, or if they're really getting to the point where there's symptoms, you know, where their body is hanging on to extra fluid because the heart is not as strong, then sometimes we'll use diuretic medicine. That's medicine that tells your kidneys to make more urine to try to rebalance the amount of fluid in the body.
Interesting. The heart is so interesting to me. Thank you both so much, Dr. Vinocur, Dr. Gillingham. We really appreciate you taking time on a Saturday to be with us. Dr. Gillingham, you're not done yet. You're going to be back with us this evening. Yes. So we can do a little bit of family cooking. So we appreciate you both. Thank you so much. If we didn't get to your questions, we will send those along to Dr. Gillingham and Dr. Vinocur, and we'll add those to our list that we'll send out in the next week or so to all attendees. So thank you both so much.